My name is Darcy Little and this is my shoulder assessment. So I've got my patient here, his name is Riley, and I've just asked him for consent for this shoulder assessment, which... Yes, perfect. So what we're going to do to start with is just pure observation. So as Riley faces the camera, what we're going to do is look at both sides of the shoulder. What we want to see is resting position, and we want to make sure that both shoulders are sitting at the same height. We're going to be paying attention to the angle of both clavicles. We want to be looking for any signs of previous injury history. We want to be looking for scarring or anything like that that can indicate they've had some surgical procedure or just some nasty injury. Different angles again of these clavicles, we want to make sure they're doing the same thing. From there, Riley's going to turn around and we're going to have a look at his back. We're going to look for signs of trap wastage, so we want to make sure that both of the traps are kind of the same kind of size and doing the same things, again creating that nice same unique angle. We're going to be looking down at the medial border of the scapula, looking for any signs of that winging scapula or any scapular dyskinesis or anything like that, which we're looking pretty good. So from observation, then we're going to step through to palpation. So I'm just going to check again with Riley that he's alright if I make contact with him now.
Yes.
Alright, so what we can do is, starting off, we'll start from the front. So what we want to do is palpate along the borders of the clavicle. Again, because we're doing this in a front-on exam, it's really quite easy for me to watch Riley's face or watch the patient's face as I'm doing this for any signs of pain and tenderness. As said before, we're trying to look for any breaking continuity, any tenderness, any thickening or any swelling. We want to go all around all joints, AC joint, we're going to go through the glenohumeral joint, sternoclavicular, head of the humerus, looking for any signs of abnormalities and any feelings of any asymmetries. So I'm going to do both sides again, injured side and uninjured side. No discomfort, no pain. No, feeling good. Alright, once we've done anterior aspects, we're going to flip him around and we're going to have a look at the scapula. So we're going to really palpate along the border of the scapula and come down that medial side. No pain?
No.
Good. And again on both sides. Again, looking for any signs of injury. As we're using our hands, we can also feel for that increase in temperature, which can indicate again that there's an injury there or arthritic changes. Okay, so pretty good. Alright, from here we move on to movement. So what Riley's going to do is he's going to mimic the same movements that I'm going to do. So I'm just going to get him to go into flexion first. So he's going to straighten his arms and go straight up as high as he can above his head. Good. And then straight back down as far as he can behind himself. Good. Now he's going to have his arms coming out straight to the side, all the way up, 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 up. Good, and then coming back down and crossing over in front of the body. Try not to flex. And then we're going to do that horizontal, so he's going to come from arms out the side. He's going to come in across his body. Yep, all the way across. And then he's going to try to extend and open his chest up as much as he can. Good, and he's going to tuck his elbows into his stomach. He's going to open his arms out to the side and then fold them across. Alright, we're also going to do that at horizontal, so he's going to come up here, opening up, and coming all the way down. Good. Alright, so for the sake of the video and the time restraints that we've got, I'm now going to passively go through the same ranges of motion of the shoulder, but we're only going to focus on flexion and extension, otherwise we're going to be here all day. So what I'm going to do now is again stabilising this joint and feeling for that crepitus as I go along. I'm just going to go into flexion and then come straight back into extension. So Riley's not providing any movement here, his arm is just completely relaxed as I'm doing the movement for him. And then we're going to do the uninjured side. Good. No pain. Good. Moving through to resisted range of motion now, we're going to do the same thing that we did before with the knee. So we're going to do concentric, eccentric and isometric. So I'm going to stabilise at the top of the shoulder. Riley's going to go into flexion and I'm going to resist it and slowly let him win. No pain. Good. And now we're going to go into extension. Slowly let him win again. He's pulling down, down, down. Good. Other side. Go into flexion for me. Good, no pain. Good, good. And now we're going to come into extension. No pain. Good. So now we're going to move on to eccentric contraction. So this time I'm going to be applying a force and Riley's going to slowly let me win. So I'm going to be pushing down and he's going to resist and smoothly and controlled let me win. And same goes again as I pull up now. So resist for me and slowly let me win. Good. No pain. Right, starting up and I'm going to push down. Good. And I'm going to pull now, so resist me. Again, paying close attention to the patient's face, looking for any signs of discomfort. Last thing we're going to do is that isometric, so we're not going to get any change in joint angle, and those muscle fibres aren't going to be changing their length. So I'm going to be holding strong here. Riley's going to try to straighten his arm up, and we're not moving. No pain. Good. We'll do the same thing here. Push. And lastly, up here, push. Good. Same coming down, so pull. Good. Here. Pulling again, and lastly down here, pull. Good. This side. Hold it. Good. Holding strong. Good. And hold strong. Good. So I pull up. Good. And hold. Good. This Alright, so now what we're going to do is combine multiple movements together. So what I'm going to get Riley to do is abduct and externally rotate and put both hands on the back of his head. And now he's going to adduct and have both hands on his back. Good. Moving pretty well. We're going to do the same thing as Riley faces the other way. So we're going to have both hands on the back of his head first, watching the way those two scapulas rotate, coming down to both hands on your back. Good. We want everything to be uniform and smooth. We're looking for any asymmetries and anything like that. From there, we're going to move on to our special tests. So, first one we're going to do, while we're here, we're going to do the subscapular lift-off test. So Riley's going to have both hands on his back there, just like he did. And what he's going to do is he's going to try to lift those hands away from his back. Good. Perfect. So a positive test would be if the patient cannot, in fact, lift their hands away from their back, and that could indicate scapular instability. Then we're going to spin around. So Riley's facing the front. We're going to do an empty can test. So what we do is we have shoulder flexed. We're going to be out to about 30 degrees. And we're going to internally rotate that hand so that it's as though he's emptying a can out. And what I'm going to do is apply a force down, and he's going to try to resist that force, which is good. We'll do the same on the other side. Internally rotate, force down, no pain. Good. So a positive test for this would be pain or weakness and letting that arm drop, and that's an indicator of rotator cuff pathology, particularly supraspinatus. From there, we're going to do a Hawkins-Kennedy impingement test, which is testing for subacromial impingement. So what I'm going to do is stabilise here, and I'm going to internally rotate that arm. If we're getting pain and discomfort again, that's a positive sign for subacromial impingement. Doing both sides. Stabilising the joint, internally rotating. Good, no pain? Good. Alright, last special test I'm going to do is I'm going to do a combination of a shoulder apprehension test as well as a relocation test. So Riley's going to lie down on his back on the table. Alright, so what's going to happen here, as we open up this shoulder joint, we are going to stabilise against our thigh here, and then we're going to externally rotate that arm, which is going to be putting a posterior to anterior force at the head of this humerus. And what we're doing is paying close attention to that patient's face to make sure there's no sign of discomfort, and we should feel that there's a firm end feel of that joint, of that range of motion. So that's our apprehension test. If we want to include a relocation test, that is where I can apply a posterior to anterior force on the head of that humerus, pushing that head of the humerus posteriorly. If that reduces pain symptoms, then we know that that's a positive test for a relocation test, which indicates signs of glenohumeral instability, which is no pain, all good. Again, we would do both sides and retest on the other side just to compare. From there, we're going to get Riley to jump up. We've done our special tests. We could do other tests. We could do O'Brien's test for a slap lesion. We can do crank test, grinds test. But from here, again, due to time restraints, we're just going to push straight through. If I had longer, I would like to do a neural assessment where I would do an upper limb tension test assessing the median nerve, radial nerve and the ulnar nerve. Again, due to the time restraints of this video, we're just going to skip ahead. So now that we've done all our special tests and we've palpated the joint and felt for any injuries there, that concludes our shoulder assessment. So thanks to Riley and thanks very much.